Good morning, and thank you for joining us today. I wanted to meet with y'all to talk with you, sorry, I'm going backwards to the cover slide, about assessing for cognitive impairment in correctional settings. Here is the kind of a brief agenda of the topics I'm going to cover. I'm going to talk a little bit about the demographics of the correctional population, which is a pretty unique population. Talk some about what cognition and cognitive impairment are and what they mean, and then talk about cognitive assessment in general. That is the bulk of our topic today, and then about some of the challenges of cognitive assessment in this population, or with this population. The unique characteristics of prisons have really important implications for assessing and treating clients in this setting, and so I'm going to begin with that, talking about the U.S. prison population. The American criminal justice system holds more than 2.3 million people in 1,719 state prisons, 102 federal prisons, 942 juvenile correctional facilities, 3,283 local jails, and 79 Indian country jails, as well as in military prisons, immigration detention facilities, civil commitment centers, and prisons in the U.S. territories. At year-end 2014, the United States held an estimated 1,561,500 prisoners in state and federal correction facilities alone, and that was a decrease of about 15,400 prisoners, about 1% down from December 31st of 2013. 13% of those, or 210,567, were in the federal system, which does include privately operated prisons, in the federal system, and then 1,350,000 plus in state facilities. 97% of those were sentenced to more than 1 year in prison, and the remaining 3% was made up of those either yet to be sentenced or those with sentences of 1 year or less. Some of the decline that you see most recently in this chart on the screen is due to the diversion of nonviolent, non-serious, non-sex offenders to local jails and community supervision, such as some states are really working on that strongly, such as California. The imprisonment rate was 612 per 100,000 for those over 18. That represents 1,169 out of every 100,000 males and 84 out of every 100,000 females. In 2014, 6% of all black males ages 30 to 39 were in prison, compared to 2% of Hispanic and 1% of white males in that same age group. Violent offenders made up 54% of the state male prison population at year-end 2013, the most recent year for which that data was available. This U.S. prison population has quadrupled over the past 25 years, as you can see on this chart, and correctional institutions are now really responsible for meeting the health care needs of these prisoners as well. The aging or graying of the prison population, which I'm going to talk more about in a bit, is rapidly increasing the costs of providing mental health care as well. And in addition to costs related to caring for prisoners with mental health needs, mentally ill prisoners have higher rates of misconduct and accidents in prison and higher recidivism rates than those without mental health problems. Females have represented approximately 7% of the total prison population over the past decade, but the number of females in 2014 represented a really large increase, the largest number since 2009. Half of the males and more than half of the females, 50% of the males and 59% of females in federal prison were also serving time for drug offenses in 2014. And although I'm not talking specifically today about juvenile detention, I found this graphic that demonstrates the different locations of incarcerated Americans between 1920 and 2014, and you can see the juvenile detention population at the very bottom of this top graphic in the light purple color, the one that's not labeled. That is, well, it is labeled beneath it, juvenile detention. I just found that to be an interesting graphic. On the lower figure, you'll see over the past 15 years, commitment to secure juvenile facilities for youth who've been adjudicated delinquent has been declining from a high point of 77,800 in 1999 to 35,000 in 2013. Thousands of young people are transferred to the adult system each year, however, and many are sent to adult prisons and jails to serve their sentences as well. And as I mentioned earlier, all across the United States, prison populations are growing old and infirm behind bars. The number of U.S. state and federal prisoners aged 65 or over grew at 94 times the rate of the total prison population between 2007 and 2010. The number of prisoners aged 65 or older increased by 63%, while the total prison population during those years increased by 0.7%. But looking at the number of U.S. state and federal prisoners aged 55 or older, that group nearly quadrupled between 1995 and 2010. It grew by 282%, while during that time frame, 1995 to 2010, the total number of prisoners grew by less than half, or 42%, during that same time. And today, nearly 16% of the country's 2+ million prisoners are over the age of 50 or elderly, as defined by the National Institute of Corrections. That may be surprising. It was surprising to me, but elderly is defined as over 50 in correctional facilities. The percentage of elderly prisoners relative to the overall prison population is, of course, expected to continue to rise with the aging of our overall population as well. By 2030, a third of all inmates will be elderly, and many prisons may look a lot like nursing homes. Most departments of correction now report spending more than 10% of the annual budget on this elderly population, on elderly care. The imposition of longer sentences in the 1980s and 90s really produced a pretty dramatic increase in the number of older adults in corrections. And of course, older adults, as in the general population, have higher rates of chronic health conditions, geriatric syndromes such as cognitive impairment or dementia, and disabilities or impaired abilities to perform activities of daily living compared with younger inmates. And so given the aging incarcerated population, prisons and jails, which were designed to hold young and healthy inmates, are increasingly becoming a site for nursing home level care and treatment for chronic conditions as well. So as you can imagine, then, prisons in the United States and jails contain an ever-growing number of aging men and women who have difficulty climbing stairs, hauling themselves to a top bunk, or walking long distances to meals or the pill line, prisoners who need wheelchairs and walkers and canes and oxygen and hearing aids, many who can't get dressed or go to the bathroom or bathe without assistance, many who are incontinent, forgetful, suffering chronic illnesses, and or dying. And then, of course, older people are more likely than other age groups to have intellectual impairments associated with cognitive disorders such as dementia. And in addition, older people are more vulnerable to head or brain injuries arising from strokes or falls. And all of these factors may result in diminished capacity to make decisions regarding their own interests, their care, as well as various personal and health and lifestyle decisions. So given the aging trend during the period of rising incarceration rates and the greater prevalence of health conditions among older inmates, again, prisons are increasingly becoming a critical delivery site for nursing home level care and care for serious chronic illness. And this rapidly increasing population of older adults in correctional facilities really underscores the importance of screening and, more important, regular rescreening for cognitive impairment, dementia, and disability. Currently, in most facilities, a disability assessment is only performed at intake, even if the individual is incarcerated for decades. So, looking at disabilities in the correctional population, more than 750,000 people with diagnosed disabilities are currently imprisoned in the United States, and of those, 500,000 have cognitive impairments. 250,000 suffer from mobility problems, and 140,000 are visually challenged. Of all of those, many are people who never had the resources or the abilities to address their disabilities, as you might imagine. And while people with diagnosed disabilities account for 20% of the overall population, more than 30% of people in prison in the United States have a disability. And you can see on this slide Bureau of Justice data comparing several types of disabilities in state and federal prisoners compared with the general population, and you can see that the prevalence of each is statistically significantly higher in prison, with the exception of those with disabilities of self-care, which is about the same. Disabilities that are relatively minor in society at large can constitute serious impediments to well-being in prison. Life in correctional facilities involves activities of daily living that pose particular challenges to people with physical or developmental disabilities. For example, Again, regular ADLs involve things like bathing and dressing, but activities of daily living in prison can also involve getting on and off an upper bunk, dropping quickly to the floor for alarms, hearing and promptly following orders against extensive background noise. You can see on the slide that I highlighted the cognitive disabilities reported. Cognitive deficits and substance abuse and mental illness are, of course, common among prisoners. This is 2011-2012 data from, again, the U.S. Department of Justice, and you can see that cognitive disability was the most commonly reported disability among inmates. And as a comparison, less than 5% of the general population suffers cognitive disabilities, but nearly 20% of state and federal prisoners do. This was self-report data, and the cognitive impairment question was, because of a physical, mental, or emotional problem, do you have serious difficulty concentrating, remembering, or making decisions? The Bureau, though, has acknowledged that there are limitations in their data that was collected for this study because they were unable to count many inmates whose cognitive disabilities were so severe that they couldn't even properly consent to the study, much less answer the question. Another finding was that 33% of prisoners and 47% of jail inmates, and I'm sorry, this slide only does show the state and federal prisoners. It doesn't show the jail numbers, but they're pretty similar. But 33% of prisoners and 47% of jail inmates with a cognitive disability reported past 30-day serious psychological distress, compared to only 11% of prisoners and 24% of jail inmates with a disability other than cognitive. So cognitive disorders they're constant, they're permanent. They include things like Down syndrome and autism and dementia and learning disorders and traumatic brain injury, and they affect how someone understands and processes information. And more importantly, they affect how someone might respond to requests or pressures from other people, for example, corrections officers or even other inmates. Those with cognitive impairment in correctional facilities have serious difficulty concentrating, remembering, or making decisions. And among female inmates, which is a growing prison demographic, as I mentioned, cognitive disabilities were also more common than among their male counterparts. This is from a study in California, the California Department of Corrections and Rehab, this data. Cognitive impairment, which, as I mentioned, is it's also sometimes known as memory impairment or referred to that way. It's characteristic of dementia and developmental disability and traumatic brain injury. The most common cause of dementia is Alzheimer's, which, of course, gradually destroys memory and reason and judgment and language and eventually the ability to carry out even simple tasks. But there's a lot of other causes of dementia and of cognitive impairment as a group. And that would include things like strokes and Parkinson's disease and HIV and traumatic brain injury, as I mentioned. About 15% of men and 11% of women not in correctional facilities over 65 have moderate to severe memory impairment. But in a survey conducted for this California Department of Corrections and Rehab for purposes of long-term care planning, they found the identification of cognitive impairment in those aged 55 and older to be very difficult. They were trying to establish the prevalence of cognitive impairment in their facilities. Correctional officers said 19% of the general population sample overall had cognitive impairment, which was defined in this study by any memory or decision-making problems, dementia, or a developmental disability. And that ranged from 15% of those aged 55 to 69 and 24% of those 70 plus. But when they pulled a small group of the general population sampled inmates who had evidence of dementia in their chart, they found that the officers had identified only 43% of those as having any sort of memory problem or other cognitive problem, suggesting that the correctional officers may really be often unaware of these kinds of problems. And officers often said in this study that they were uncomfortable making an assessment of memory problems. One of the reasons that they noted, of course, was that they couldn't tell if inmates were using their age to fake memory impairment. But the study found inmates in these facilities with good functional ability and minimal comorbid conditions failing in general population because of their cognitive impairment. And then other inmates in the general population had cognitive impairment and severe functional impairments. For example, an 82-year-old man with heart disease and vision and hearing impairment, Is wheelchair-bound, following a stroke, has to have supervision when transferring from his wheelchair, requires extensive help with all other ADLs, including toileting. Cognitively, he doesn't recall the names and faces of his officers or his cellmates, and his correctional officer described him as fragile and frail and unsafe. In a chart review during this study, there was no evidence of any dementia screening with any sort of test for this particular individual. Looking briefly at mental illness, which is not the focus of today, but just because you can't not mention it, most literature on mental illness in correctional facilities does include mental or cognitive impairment in the definition, and so that kind of compounds or makes some of the studies a little difficult to tease out. DSM-5 defines mental disorder as a syndrome characterized by clinically significant disturbance in an individual's cognition, emotional regulation, or behavior that reflects a dysfunction in the psychological, biological, or developmental processes underlying mental functioning. In the U.S., the percentage of inmates with mental illness has been steadily increasing, with rates more than quadrupling from 1998 to 2006. Bureau of Justice statistics show that over half of all prisoners in 2005 had experienced mental illness that was identified in that study or that report by a recent history or symptoms of a mental health problem. And of this population, jail inmates experience the highest rates of symptoms of mental illness at 60%, followed by 49% of state prisoners and 40% of federal prisoners. So not only do people with recent histories of mental illness end up incarcerated, but many who have no history of mental illness also end up developing symptoms while in prison. And of course, although many argue that prisons have become the facilities for the mentally ill, very few crimes actually point directly to symptoms of mental illness as their sole cause. Despite the disproportionate representation of mentally ill persons in prison, a study by the American Psychological Association indicates that only 7.5% of crimes committed were found to be directly related to mental illness. So looking at intellectual impairment in correctional settings, lower intellectual functioning as a cognitive disability shouldn't be confused with mental illness, which of course can often be treated by medication or therapy. Individuals with below average intellectual functioning may be considered a really vulnerable group for a range of reasons, including being scholastically and vocationally and socially disadvantaged, and they remain vulnerable throughout their life course. One particular problem is that they are at a disproportionately high risk of coming into contact with the criminal justice system. There is a sizable body of research now focused on attempting to determine the strength of the relationship between lower intellectual functioning and risk of committing criminal offenses. Intelligence is frequently assessed to meet NCCHC standards, state requirements, and standards of care, and to maximize the use of support programming such as vocational and literacy and social skills training. Again, the relations of intelligence and criminal behavior has been widely studied, and intelligence has been found to be a strong predictor of criminal behavior, with higher intelligence being associated with less criminal involvement. Recent findings indicate that intelligence is significantly and inversely related to violent prison misconduct at both the group and the individual level. Individual level intelligence differences is significantly related to violent misconduct. A one standard deviation increase in an individual's IQ score is associated with 10% reduced odds of violent misconduct, and the average IQ of prisoners within a prison unit significantly predicts inmate violent misconduct. So assessing both the average group intelligence of facilities and the individual intelligence of inmates may be really helpful for safety and prevention. The NCCHC position statement on violence prevention indicates that correctional health services should incorporate violence risk assessment into receiving screening of all inmates upon intake and develop protocols and guidelines for violence prevention. But this position statement, coupled with this now known association between violent misconduct in correctional facilities, suggests that intelligence assessment in correctional environments is a standard of care and important for risk management. Much of this recent info is from a 2012 study by Diamond et al. From UT Dallas, and that study examined that relationship between intelligence and violent misconduct in prison and showed that inmates with above average IQs were at a reduced risk of being involved in a violent incident. Again, and that individuals assigned to units with a higher average IQ score were significantly less likely to commit violent behavior. So generally, an individual's IQ is thought to capture the ability to navigate a social environment in addition to assessing academic capabilities. People with lower IQ are seen to be more prone to respond physically and lack that advanced repertoire for handling situations. In addition, looking briefly at ADHD, studies show that there is an overrepresentation of ADHD in our correctional system. People with ADHD account for a number of the inmates incarcerated in prisons. A meta-analysis of 42 studies looked at the prevalence of ADHD in incarcerated populations across countries and compared those in prison with ADHD versus the general population. And the meta-analysis found that there is a 5-fold increase in prevalence of ADHD in youth prison populations and a 10-fold increase in adult prison populations. So there's a clear societal cost of ADHD in the world, and its identification and treatment is important in all settings, but again, they're overrepresented in prison settings. One more study of ADHD in prison was done by Ginsberg et al. In 2010, and they also found that a large number of individuals in long-term incarceration had ADHD, 40%, but only 2 out of 30 of those prison inmates had been diagnosed during childhood. The diagnosis was missed. So while 6.7% of prison inmates in that study confirmed that they'd been diagnosed with ADHD in childhood, 40% of them are estimated to have ADHD as adults. And one more on ADHD. This is a study conducted in Sweden, and this found that the treatment of ADHD was actually linked to the likelihood of being in prison. Among those patients with ADHD who were taking medication for ADHD, there was a 32% reduction in the criminality rate for men and a 41% reduction in women. And this reduction in crime was notable even when different drugs were used and when both violent and nonviolent crimes were tracked. And that study, not as relevant to what we're talking about today, but just really interesting to me. It really questioned whether or not we can help prevent people from going to jail if we identify and treat ADHD earlier. But even once there, can we help curb some of the oppositional and conduct disordered behavior? Again, many inmates in prison have undiagnosed ADHD and are untreated. So looking briefly too at inmate health, just to round up the demographic section, a number of social determinants are strongly associated with poor health. In the United States, these are things like being non-white, having low income, being undereducated, being homeless, being uninsured. Those are among the strongest predictors of poor health. When compared with the general population, individuals in jails and prisons exhibit these predictors of poor health disproportionately, as you might expect. As a result, the population of inmates typically share a number of health profile characteristics, including mental health disorders, drug dependence, infectious disease, and chronic conditions, and cognitive impairment. Moreover, some groups pose really unique challenges to correctional health care. TBI is one of those groups. Many people in prisons and jails are living with traumatic brain injury-related problems that complicate their management and treatment while they're incarcerated and also pose significant challenges when they return to the community. The CDC considers this a really important public health problem. Cognitive deficits overall, including those resulting from TBI, make it really difficult for offenders to focus on required tasks, to respond to direction, and understand or remember rules. Jail and prison studies as a group report that between 25 and 87% of inmates report having experienced a head injury or TBI, as compared to 9.5% in a general population reporting a history of TBI. Women inmates who are convicted of a violent crime are more likely to have sustained a pre-crime TBI and or some other form of physical abuse. And of course, among male prisoners, a history of TBI is strongly associated with perpetration of domestic or other kinds of violence. So looking quickly at just cognition and cognitive impairment, I want to define some terms first. Cognition is the processes of knowing, including attending, remembering, and reasoning, also the content of the processes, such as the concepts and memories. Cognitive impairment means that there's been a change in how a person thinks or reacts to emotions or behaves, and this can range from just mild memory problems to an inability to think independently. In normal aging, stable parts of memory are those remote memories, crystallized abilities, and remembering the gist of information. What changes as we age as a group is new learning, depth and speed of processing, recall of details of new information or events, and nonverbal memory. We'll talk some more about that toward the end. Cognitive disorders are a part of the neurocognitive disorder classification in the 5th edition of the DSM-5, the Diagnostic and Statistical Manual of Mental Disorders 5, and they're defined as any disorder that significantly impairs the cognitive function of an individual to the point where normal functioning in society is impossible without treatment. And so some common cognitive disorders include dementia, developmental disorders, motor skills disorders, amnesia, substance abuse, cognitive impairment. Cognitive impairment can be present at birth. It can be the result of a birth complication or injury such as lack of oxygen. It is usually called, formerly called mental retardation, now intellectual disability when it's present this early. It can also occur later in life, of course, from the use of alcohol or drugs, the abuse of prescription medications or other chemicals, a disease such as Alzheimer's disease or another type of dementia. It can be a side effect of some medications, or it can be caused by trauma such as a head trauma. Cognitive impairment has a really significant impact in correctional facilities on individual inmates, peer inmates, and staff, as I've mentioned. Cognitive impairment, including dementia-related conditions, often goes unrecognized and undiagnosed. Cognitively impaired inmates have great difficulty functioning in general population due to poor decision-making and behaviors that inhibit the ability to follow instructions. The behavior of cognitively impaired inmates can be misinterpreted as problematic or unruly. It can result in disciplinary action when the inmate may not understand what they're doing or what's being asked of them. Cognitively impaired inmates have a higher victim potential. Prisons often characterized as a frightening and traumatizing environment, as aggression and violence and bullying are part of the culture in most correctional facilities. Both older and younger adults who have increasing symptoms of dementia or other types of cognitive impairment are at an increased vulnerability to victimization by other prisoners, or they may become aggressive to staff or other prisoners, resulting in reprimands or charges. Older adults with dementia are often targets of other inmates, especially including bullying, being made fun of in an attempt to provoke them. When the self-defense response is violent, it can result in disciplinary action. One of the most important and basic rules of survival in prison is to follow directions, right, to avoid disciplinary infractions and to remain as physically independent as possible. So being obedient is essential for survival and avoiding charges that may result in secure confinement. Being vigilant to rapidly responding to authority in the prison environment and responding to prisoner leaders can be far too complex for some of those with cognitive impairment who suffer loss of short or long-term memory, along with impairment in other areas such as reasoning or personality, language, visual processes, executive functioning, behaviors, and relationships. And as these impairments affect people's level of independence, such as their ability to perform those activities of daily living, like maybe even eating for themselves, feeding themselves, and their social relationships, again, they may not be able to follow prison rules, and they run the risk of receiving charges that may result in confinement, which also will significantly compromise their physical and mental well-being. It may be impractical to conduct traditional head counts with cognitively impaired inmates who suffer from poor concentration or confabulation. There may be a question of whether cognitively impaired inmates should be put in lockdown for problematic behavior when they may not remember the behavior 5 minutes later. Staff sometimes will have to adjust to the need to be in close contact with an inmate in order to get their attention via touch, and this can be, of course, an adjustment for officers who are accustomed to facing down a problematic inmate or filling out a report with every physical interaction or touch. This slide shows some of the functional consequences of cognitive impairment at even a mild level of cognitive impairment. You can see things on here that you recognize probably in people that you see in the general population, certainly, but also for those of you who work in correctional facilities. Cognitive disorder signs vary, of course, according to the particular disorder, but some common signs and symptoms overlap in most disorders, and some of the most common signs of cognitive disorder include things like confusion and even poor motor coordination, loss of short-term or long-term memory, identity confusion, impaired judgment. Some cognitive disorders develop in stages, and symptoms increase in severity the further the disease progresses. Alzheimer's disease, for example, usually begins with the patient showing minor signs of forgetfulness. Sufferers may forget names that they know well. They may have trouble remembering what they did recently. And that early, those initial symptoms of early onset Alzheimer's disease are often indistinguishable from normal memory errors. But as the disease progresses, the affected person's memory becomes persistently impaired. They may have rare moments of clarity, but life is generally lived in a state of confusion, which, as you can imagine, in prison can be just terrifying. A reevaluation really should be performed when an individual or a visiting family member or any sort of caregiver or staff become aware of a decline in mental functioning, which impairs memory or learning or attention, or the ability just to function independently in the environment. Some of the importance or benefits of assessing cognition in correctional populations are, of course, the NCCHC standards, which do require an initial intake and in-depth assessment. Many states do have various requirements for standards of care around cognitive assessment, not all. There is, of course, an efficiency and benefit of support programming that would be available for a person whose needs were better understood. And, of course, we want to be able to predict violent misconduct. I've mentioned the studies associating IQ with violent misconduct. But because it affects decision-making and behavior, it's really important to understand and assess in order to respond to inmates appropriately because of the potential increases for poor decision-making and victimization and problematic behavior. The actions of a person with cognitive impairment may be symptoms of disease rather than deliberately intended acts of aggression or hostility. And so identification allows for the management and the mitigation of behavioral problems associated with cognitive impairment, including dementia-related conditions. It allows staff to be trained to recognize and understand and deal with inmates and their behaviors in light of their cognitive impairment. It provides staff with appropriate techniques to deal with potential situations and handle characteristic behaviors in a different way than they would have previously. It helps them understand conditions and recognize the linkage between inmate conditions and behaviors and make informed decisions about how to approach and interact with inmates. It can help identify strengths that can help the person being evaluated function at the maximum level of independence and identify weaknesses or impairments which really may necessitate changes even to the environment or the level of care. Helps determine level of care and supervision and when changes to level of care need to be made. Also, when looking at discharge, prisoners with cognitive impairment have significant difficulty after release, of course, because they may not have appropriate placements due to the complex multi-issue nature of their conditions if these needs are not fully understood and known. So identification allows for post-release placement and establishing connections with healthcare and criminal justice and support networks in the community. So similar to community population, persons with dementia in prison really struggle with gradual, irreversible loss of memory, judgment, functional abilities, health, and eventually threats to one's personhood. This is, of course, about dementia. The individual and the collective financial cost of caring for persons with dementia is especially high in prisons. It's estimated that 13% of individuals 65 and over in the U.S. Not in correctional facilities, have some degree of dementia, but there has been no national study to estimate the prevalence of dementia among the U.S. prison population. Looking at mental retardation / intellectual disability, sorry, I need to change that slide. The symptoms would be things that we've mentioned earlier: poor adaptive functioning from birth. It is related to intelligence, not to mental illness or personality. Symptoms in jail, of course, should not be confused with mental illness, but require a significant amount of patience and an understanding of the person's specific abilities. And again, traumatic brain injury in prisons and jails, attention deficits that are common in traumatic brain injuries may make it difficult for prisoners with TBI to focus on the required task or respond to directions given by a correctional officer. These situations can be easily misinterpreted, leading to an impression of deliberate defiance on the part of the prisoner. Memory deficits can make it difficult to understand or remember rules or directions. Irritability or anger may be difficult to control and can lead to incidents with either other prisoners or with staff and to injury. Slowed verbal and physical responses may be interpreted as uncooperativeness, uninhibited or impulsive behaviors, which are also very common in many traumatic brain injuries. these would include things like controlling problems with anger and unacceptable sexual behaviors. And those kinds of behaviors may really provoke other prisoners or, again, result in disciplinary actions. TBI experts and many prison officials have suggested routine screening of jail and prison inmates to identify a history of TBI, screening for alcohol and substance abuse, and treatment for these co-occurring conditions, and additional evaluations to identify those specific TBI-related problems in order to determine how they should be managed. Offenders with limited cognitive capabilities, regardless of the origin, really have deficits that cause difficulties adapting to prison. In a correctional environment, functioning deficits really create serious problems for an offender. So the primary goal of screening or assessment for offenders with disabilities is to address their unique needs and to provide them with opportunities to acquire skills, if possible, that will reduce those deficit-related behavioral problems and victimization, and for those who will be released, to promote successful reintegration back into the community. So just briefly, the diagnosis of cognitive impairment is usually made according to the type of impairment. It is made according to the Diagnostic and Statistical Manual 5 criteria for the specific condition. Dementia is now, and amnestic disorder is now included under what's called neurocognitive disorder in the DSM-5. It had been associated with older populations previously, but neurocognitive disorder really expands this category to include etiologies occurring in younger adults. Dementia has been identified as a national public health priority, especially because of the projected growth in the number of Americans affected by this illness, including older adults and younger adults in prison. Let's see. What do I want to say? DSM-5 recommends, when screening for cognitive assessment or evaluating cognitive assessment, domain-oriented cognitive assessment, which we're going to talk about in a few minutes, but complex attention, executive function, learning and memory, language, perceptual motor, and social cognition. So looking at cognitive assessment, cognitive assessment is typically conducted for diagnostic purposes, for patient care and planning purposes, and for treatment and rehab purposes. Of course, for prisoners, evaluations may be indicated to assess for impairment, to determine the degree of impairment, and how these impairments may affect the behavior in the prison environment at both the point of entry and should be also conducted when there is suspected change or decline. The U.S., again, has the highest incarceration rates in the world. We hold nearly 25% of the world's prisoners, and as I've mentioned, a disproportionate share of the jail and prison population have mental health issues at a far higher rate than the general population. The majority of facilities do some screening. Cognitive ability and academic achievement and mental status all have an impact on success during a correctional stay and the move back into society, so the majority of the facilities do some type of assessment. Many state correctional system intake facilities require a mental health screening within 24 hours of admission, and this screening typically does include an intelligence test. The NCCHC standards for jails and prisons state that post-admission mental health assessment should include intelligence tests to screen for intellectual disability among inmates. Group tests of intelligence or brief screening instruments may be used initially, and then individually administered comprehensive instruments used to follow up on results from group tests that indicate an inmate may have a disability, a cognitive disability. A mental health screening was required within 24 hours of inmate admission in 74% of state prison system intake facilities in 2004. 68% of states used intelligence tests during the intake process, and 50% of states required intelligence testing upon intake. It's really important to assess intelligence in inmate populations, again, in order to maximize the effective use of vocational literacy and social skills program resources. So you begin, of course, by being clear about the purpose of the evaluation, understanding who you're conducting the evaluation for, and understanding what available history there is to understand. Again, you want to look at the areas of attention and executive functioning and learning and memory and language and perceptual motor and cognition. Memory is one of the major complaints. When people see or begin to notice cognitive change, that is usually maybe the most common complaint that people have. Cognitive tests tap multiple domains because our neuropsych function depends on neural systems rather than focal brain regions, and it's usually the overall pattern of test findings rather than a particular test score that's important when you're interpreting results. The overall pattern will show abilities or sets of abilities that are maybe below expectation or impaired or not. This pattern is what is helpful in diagnosing specific disorders and in suggesting compensatory strategies that may be helpful. So of course, I put the word ideal in parentheses because I get it that that's not always possible, but I was taught that you always have to shoot for the gold standard, otherwise you are shooting for something less than ideal. If you don't, if it's not possible in every facility, it's not. But the ideal evaluation process would begin with an interview, which would include current mental status, the inmate's understanding of the purpose of the evaluation, any prior psychiatric history, the social aspects of their situation, etc. The history can really be the most important part of an evaluation when you're looking at whether or not somebody's cognitive abilities have changed. So you want to the degree possible, gather information from the patient and from collateral sources. You want a description of their behaviors, their cognitive and memory functioning and problems and their effect on their activities of daily living. You want to look at onset time in the course of an illness, whether or not problems have been chronic or progressive or stepwise. That helps in determining the type of problem. Whether or not the problems are static, like they would be in traumatic injury or an episode of severe hypotension. You want to look for treatable causes. There are many types of cognitive problems or impairments that can be treated, including things like cardiovascular risk factors such as smoking and hypertension and diabetes, normal pressure hydrocephalus, metabolic disorders, medication problems, sleep apnea, things like that. If you want to do a medical record review, looking for the medical history that you haven't been able to obtain from the patient or the collateral, look at medications, to see if there's been, serum and urine analysis, illegal substances present, specific drug levels, imaging if it's been done, CT, MRI, or PET scan, and then behavioral reports, of course, looking for reports of compliance or even change. And then observation. You want to look at the person's ability to learn and retain new information, handle complex tasks, their reasoning ability, their spatial ability and orientation, their language, their behavior, their gait, vision, and hearing, etc. So during your interview and your history taking, you want to be assessing their orientation, their communication, their ability to speak and understand and respond appropriately to you, their judgment, so their insight into their situation, their appearance and behavior, their general intelligence, their mood, their ability to attend to visual cues, attending to both right and left sides of the body, looking for awareness of cognitive change or unusual behaviors. And then the next step, of course, is the formal assessment process, where testing is, again, the ideal, the gold standard, of course. The standardized method of assessment is that testing is performed in a structured, controlled environment. The patient is seen alone. And that the test results are then compared with scores from other patients the same age and education levels. I'm going to talk about accommodations in a few minutes and briefly about norms as well. These are some factors that influence performance, and it is just important to ensure that examinees have what they need: glasses, hearing aids, pocket talkers if necessary, adequate lighting, that they're able to be seated comfortably, determine that they're not in physical pain. You want to watch for that, or over medication if there's a medication. If they're having trouble staying awake or they appear confused or lethargic, you want to maybe assess at a different time. These are just all factors that can affect a person's performance and ability to give you their best performance. And remember that many inmates will have at least one type of disability, including those things you see here. There are some normal declines in vision with aging, including diminished focus up close and diminished color perception and contrast sensitivity, decreased vision in low light, things like that. Many people have hearing loss. They also, as they age, have declines in motor speed and coordination and balance and gait. And so, again, you want to provide accommodations to the degree possible. There are some technological solutions using hearing aids and pocket talkers and avoiding noisy environments and things like that. You just really want to make sure that you're attending to that, using magnifiers if you need to, making sure, again, that they have glasses, or referring them for a visual or hearing eval if that's going to impact their performance. You're after, when you're assessing cognition, you're after their maximum performance. And I understand that motivation and effort play a large role, but again, you have to shoot for the highest standard. Okay, looking at attention. Attention determines what information is perceived and processed and remembered. Deficits in attention can be caused by delirium or medication, or medication-induced delirium, or some other causes. So it's really important to rule out problems in attention or rule out delirium. Deficits in attention really can dramatically alter test results for any other cognitive domain, sometimes rendering other test results uninterpretable. But common attention deficits include having difficulty attending unless input is really restricted or simplified, experiencing decreased information processing speed, having processing of information taking longer than usual. They may have increased difficulty in environments with multiple stimuli, which you can imagine is a constant in correctional facilities. Difficulty holding new information in mind. They may be unable to perform mental calculations. They're processing slower than normal, again, and the components to be processed need to be really simplified to few or even one at a time. So major impairment here will really manifest as diminished attention, especially with multiple stimuli. Mild impairment here would maybe cause a person to take longer at tasks than normal. Executive functions are those higher order cognitive functions that involve planning and working memory and taking initiative and set shifting and attention and impulse control. And these are really crucial for self-regulation. They may be the most serious and complex impairments of all. There was a meta-analysis of studies of executive function in prison that found distinct executive functions deficits in attention and set shifting and working memory and problem solving and inhibition at a really high rate in prison systems, in correctional facilities. One executive function is inhibition, and that comprises deliberately suppressing one's dominant responses or impulses in order to think before acting aggressively, for example. So you can imagine prisoners may have difficulty suppressing harmful impulses such as aggressive impulses if they have executive functioning deficits. Let's see. What else do I want to say about executive functioning? Major impairment in executive functioning would really potentially cause a person to abandon complex activities. Mild impairment would cause them to utilize greater effort, especially in those tasks that require multitasking. Memory, again, I mentioned that it's the most common referral concern. It should include a list learning task to assess, and verbal as well as nonverbal learning and memory tests. You want to distinguish between encoding and retrieval problems, between recent and remote, between visual and verbal, between declarative and procedural. Examples of symptoms here may include someone repeating themselves in conversation, someone who can't keep track of a short list of items, or who requires frequent reminders to orient to the task at hand. Milder symptoms would include someone who has difficulty recalling recent events or relying increasingly on written reminders or calendars or lists. And then language, verbal ability. Language, of course, allows us to translate thought into symbols that can be shared among individuals. So you want to look at comprehension or receptive speech, which involves following simple and more complex commands. So the ability to respond to questions, to react appropriately to comments, and the ability to respond to instructions for simple tests. So examples of symptoms here would really be someone who has significant difficulties with receptive or expressive language. They may use language phrases such as that thing or you know what I mean. They may prefer general pronouns rather than names. If the impairment's severe, they may not know the names of cellmates or family. For milder impairment, you may just see noticeable word-finding difficulty or frequent substitutions, word substitutions. And then visual-spatial, visual-constructive functioning is involved in processing and manipulation of visual information from the environment, so maneuvering through the environment, locating other people or items in a busy environment. So evaluation is going to look at visual acuity, visual attention, scanning, perception, things like the judgment of line orientation task or clock drawing. So someone here would have significant difficulties with previously familiar activities if there was an impairment. Things like using tools or driving motor vehicles in the community, maybe difficulty navigating in familiar environments. They may get more confused at dusk when shadows and changing light changes perceptions. Or they may just simply show milder symptoms like the need to rely more on others for directions, again, needing to use notes or maybe to follow someone else to get somewhere. They may get lost if they're not concentrating. Spatial tasks just take greater effort than before. And several instruments for intelligence screening are often used in correctional settings, and I just wanted to put those up here. I didn't want this to be about specific instruments per se, but these are some that have been used often in correctional settings. The Shipley is a brief self-administered test, and it's been widely used in correctional settings. It can be administered in group or individual mode. The GAMMA, the General Ability Measure of Adults, is another frequently used intelligence screening instrument, provides a brief nonverbal measure of general intellectual ability for adults age 18 to 90. Excuse me. The Beta is another widely used measure of IQ in correction settings. The Beta 4 is the most recent version. It's specifically designed with the corrections population in mind. It includes tests of reasoning and visual spatial ability and processing speed, and it provides an IQ score. It's really simple to administer and score and interpret, and it was normed to accommodate administration by trained corrections officers. It's also either group or individually administered. And then the WAIS-4, of course, is the most widely used individually administered comprehensive intelligence test in correction facilities. It of course, doubles the administration time of the Beta, but it also provides additional information if necessary. This is just another area. I've mentioned activities of daily living several times in how cognitive impairments and cognitive loss and conditions such as dementia have a really important impact on the capacity to conduct activities of daily living that really results in a lot of dependency and distress and reduced quality of life. And so it is another area that is important to assess when looking at a person's cognitive abilities, just so you can see more specifically what specific areas or what specific functional areas are involved in the level of impairment. And then other areas that are also, when possible, important to assess include social cognition and affect and other psychological functioning, the types of assessments that you're probably more familiar with in correctional settings. And then, generally, for example, the diagnosis of dementia refers to an acquired impairment of multiple neurocognitive domains, and that is usually the term neurocognitive or dementia is usually, or the term dementia is usually restricted to progressive syndromes in the most common, or the most common of which are things like Alzheimer's disease and vascular disease. Those account for more than 80% of all forms of dementia, but there are, of course, other diseases and other causes of cognitive impairment, several of which I've talked about today. So when you're evaluating patients who are suspected of having cognitive disorders or impairment in various types of cognition, you really are attempting to answer the following questions. 1, is there evidence for some type of an acquired impairment? 2, what are the nature of the deficits? If deficits are detected, then 3, what is the likely associated disease process? And 4, maybe most important here, what interventions are appropriate? I've listed here some recommendations for impairments in the various domains. Not all of these are specific to correctional facilities. They are all specific to the various types of impairments. But many of them are. So, for example, attentional impairments, with attentional impairments, you would want to help staff understand that information that's presented to someone who has impaired attention needs to have the information presented in a minimal way, in a simple way, 1 step or 2 steps at a time, that the person needs to speak slowly, giving the inmate time to process each unit of information. Maybe one thought or one idea or one request or command in a phrase or a sentence. At times, a person may need to be reoriented frequently. They may need multiple chances to learn new information. They may have difficulty responding to rapidly changing task demands. Here's some recommendations for executive impairment. They really may need help with anything from dressing themselves to medical decision-making and planning, discharge planning certainly if it's relevant. And of course, the worse the impairment here, the more structured and controlled environment is needed. It's important to not assume an impaired person can do something that he or she really can't do. With memory impairments, you want to really be patient, keep incoming information simple, have the person repeat information, and use memory assistance, so signs and other visual cues, alarms, calendars, pictures. You really want to simplify the environmental demands. Here's some recommendations for language impairments. I'm going to skip past some of these language and visual-spatial impairments so I can get to the last section quickly. Treatment planning and implications just is, a means of thinking about whether or not there's other referrals that you need to be made, what types of day-to-day assistance would this person need, are there environmental changes or changes in the way a person or staff communicates with an inmate, does it change the level of supervision, are there medications that can help, etc. So there are several specific issues to consider when selecting a test in correctional settings, including literacy and language, the aging population, time constraints, and flexibility. And I'm sorry, I'm right up at the end of our time. I'm going to keep going here for a few more minutes, but I apologize for not leaving enough time to cover this in a more thorough fashion. Many of the challenges are, of course, the setting itself, the aging population, normal declines with aging, instrument selection, and effort and motivation. The nature of the relationship with the referring party, often correctional staff, is important. It's important, again, to understand the restrictions of the environment in which you're providing the assessment, so including things like privacy and confidentiality, informed consent. They must provide informed consent even in prisons, and you have to make inmates aware that they have the right to refuse to participate. Also, acting on assessment recommendations can be difficult, so it's important to kind of understand what's possible and work with the specific correctional staff and provide them a context using your results for working with inmates and help guide any rehab efforts. Sorry, I flipped past to the aging inmate slide. Of course, we've talked some about this already. It's a large, growing, and costly population, so the need for cognitive assessment and reassessment will continue to grow rapidly. There's not enough examiners who are trained in geriatric assessment to fill the need even in the outside world. But the benefits of learning about the cognitive status of inmates as individuals and as groups can't be overstated. So just that is going to continue to increase, that demand will continue to increase. There are some normal cognitive changes with age. It's really it's a common misperception that all areas of cognition decline with age, but there are some normal common declines with age. The most common finding is slowed speed of processing, as I mentioned. Crystallized intelligence usually remains intact, while declines in fluid reasoning are involved. Problem-solving related to strategies previously learned remains intact, but novel problem-solving approaches are more difficult. So there's a decrease in tasks that involve quick thinking and information manipulation, activities involving allocation and reallocation of attention. Those are things that are pretty frequent demands, task demands in a correctional environment. So it's important to just be aware with normal expected changes with age, and again the importance of continuing to be alert to the need for rescreening or reevaluation of cognitive ability in people. And then, of course, considerations regarding the testing environment are important. As I mentioned earlier, adequate lighting and ventilation and reasonable soundproofing, the possibility of physical and sensory limitations, etc. But there's some other unique obstacles that clinicians encounter when conducting assessment in the prison environment. For example, logistical difficulties, the lack of testing space, insufficient testing time, safety issues, the lack of available security staff, obligatory handcuffs during testing, trying to determine who will act as observer or rater for instruments that require an informant. It's important to conduct cognitive evals to assess the degree of impairment and how these impairments may affect their behavior in the prison environment, but there are many tests that weren't even designed for or normed on prisoners. So the average test scores or norms for most evaluations have been developed from typical non-prison populations, which brings their validity for inmates into question and makes interpretation of results difficult. And so incarcerated individuals really do differ in many important ways than those from which the norms were developed. So in the absence of norms for correctional populations, and there are some instruments that do include those, and I showed you a few of those for intellectual assessment a few minutes ago, but for many there are not, and so the clinician really needs to weigh the potential benefits and costs of assessment and interpret results with caution and inform the people for whom you're conducting the evaluation of the limits of the applicability of the results to the prison population. Tests should be culturally fair to accommodate the diversity of the inmate population, including the increasing proportions of inmates who are Spanish speakers. Literacy is an important concern. I have one more slide. I'm so sorry that I went right up 1 minute past here. But effort is something that is kind of an elephant in the room in terms of assessment in correctional facilities, and I had already determined that there was no way that I could sufficiently cover this issue in this session. And so what I want to say is, please spend some time. There are many studies of effort that have been done, but they're compounded by a lot of types of psychiatric and neurocognitive impairment. The recommendation basically is to administer multiple performance validity tests interspersed throughout an assessment session and cover multiple cognitive domains, but also spend some time learning about performance validity testing in at-risk populations. There are some good trainings out there. There are people that are certainly expert at that, or who spend time researching effort and motivation in at-risk populations. As you can see on the slide, the incentive for feigning in this population is, of course, higher than in others. And so it's important to be aware of this issue and to learn about it so that you can do your best to assess effort and motivation in this population as well. I am at 11:02. I'm sorry. Thank you. Thank you very much for attending. Please send me questions if, obviously I didn't have time to answer the questions in the chat box today, but I will be happy to either look for or send you answers to the questions that you have. So please email me if you have questions. Call customer service if you have questions about our particular instruments. And again, thank you very much.